So it's 11 a.m., so I'll go ahead and kind of get started. And anyone else who is joining, we please just ask that you mute. So hi, everybody. I'm Laura from NextJump, and I'll be moderating today's session, which is a COVID-19 presentation from Trevor. Major Trevor Peterson, who is the Chief of Medical Staff at Eielson Air Force Base out in Alaska. So thank you so much for joining us today. And we're really excited to have you all for our very first online academy. Before we get started, wanted to walk through a few administrative details on how the session will run. I think many of you have heard me as you join the call. We ask you please turn your video on. We're all in different places, so it's really great to have a sense of community. We want to see all your faces. Also recommend that if you would like to see everyone, you can turn on your gallery view as a view option. Can see we have almost 60 people on the call today, which is amazing. And then you can also switch it to a speaker view if you want to see just Trevor while he is speaking and switch back and forth. We ask that you please keep your mic on mute throughout the presentation so that we can preserve the audio quality of the presenter. If you have any questions, we will give you the opportunity. We ask that you please hold them to the end. We're going to leave the last 10 minutes of the session for questions. You can use the raise hand feature. I'll help call on you, but we'll just ask them out loud and Trevor will give you a moment to respond. Also, we'll leave the last 5 minutes for feedback in the session to either Trevor or myself in the feedback app, so you all have access to our World app. Our one ask from these sessions is that if you could please leave feedback for us that we can make these sessions better. Our intent is to run these weekly, so any feedback is greatly appreciated so that we can improve the next section for everyone else. But with that, I want to hand it over to Major Trevor Peterson. And
all right, just quick, this is Charlie Kim from Next Show before we kick off. Trevor, absolutely. Thank you for taking the time in Alaska. I think it's 7 a.m. and I know you've got crazy COVID stuff in the medical side. Just a heads up, we were in Alaska just a week ago. Trevor, I love the cup from the Academy he's drinking from. But we were in Alaska and Trevor came to our leadership academies. He's a great guy, an individual who has tremendous knowledge. And honestly, I just liked Trevor without even knowing that he was the chief of medical there or the head medical guy. So he had so much knowledge and we challenged him last week saying, I want to know what Trevor's outrageous plan would be for coronavirus and what he would do. And he just started blurbing and ranting about all these things. And I was like, oh my God, I want to write every single piece down. So we asked him a favor to try to get on this call and just share as much knowledge and then go for questions. So without further ado, I'll pass you over to Trevor.
Awesome. Well, thank you for that, Charlie. And thank you for having me, Laura. Again, my name is Trevor Peterson. I'm a family medicine physician up here at Eielson Air Force Base. And so what I'm hoping to do today is kind of give a brief overview and share kind of my understanding of the COVID-19 pandemic. Before we get started, just a couple of disclaimers. First off, the views here are my own professional opinion. They don't necessarily reflect the views of the Air Force, the DoD, or the Defense Health Agency for whom I work. Also, this should not be construed as medical advice. It's for educational purposes only. I don't have a license to practice medicine in any of the various states y'all are sitting in. And finally, that this information is as up to date as I could get as of last night. This is an evolving situation and a certain amount of inaccuracy is expected in the data points, which we'll get to in a bit. This presentation in general is one that I put together for our professional staff and has kind of been a patchwork of evolution over the last couple of weeks. So please excuse some of the formatting. I haven't had a chance to go through and refine a lot of it, but grossly what we're going to try to cover today is some basic virology, because I think that helps to frame the discussion and some of the important concepts with COVID. We'll talk about specifically what COVID is and some definitional terms. We'll talk about where the pandemic is, although we're really just briefly going to touch on that. I feel like the open source media and the news is more than adequately covering the current state. And then I'm going to try to compel all of us to take this seriously and to care about COVID-19 and talk very briefly about some stuff we should do and leave plenty of time for questions, because I actually find that when we're talking about medical things, the questions tend to be more value added than straight didactics for the general population. So let's talk briefly about virology. I think this gets misconstrued so often in the media and when I talk to patients. Viruses are distinctly different than bacteria, and it's really important that we understand that. because viruses, by their very nature, are just strands of DNA or RNA, genetic material, that's encapsulated in a protein. They're not actually living creatures. They require our intracellular machinery, so the machinery we use to make new cells, in order to survive and replicate. This is important because of the way they work. The virus comes along, it finds one of your host cells, a cell that is compatible with it entering. It enters that cell, and then it goes about hijacking your cellular machinery to create millions of copies of itself. This is crucial to understand because that indicates there's a period of time from the time you were exposed to that virus to the time you will show symptoms, or we can even test for it. Because it's all intracellular at that point, and it's not coming out of your cells necessarily. The period of time from whence you were exposed, the period of time you start having symptoms, is kind of called the incubation period of time. And that it's varying based on the virus, but the important thing to understand is you don't start getting those symptoms until you have enough hijacking of cellular machinery to tell your immune system something's wrong and for your immune system to react. And when that happens, based upon where that virus has invaded is where you're going to get symptoms. How much of an immune response you get indicates how severe those symptoms are going to be. That's sort of a broad strokes, but I think that's important to understand when we're talking about how this virus spreads. So what is COVID-19? The terminology here I think is helpful for the discussion. COVID-19 refers to the coronavirus disease that we've identified in 2019. So it's actually the disease state. The virus is actually temporarily named the severe acute respiratory syndrome coronavirus 2 in order to disambiguate it from the SARS outbreak in 2012. This virus is very closely related. It was identified in central China, as you probably know, after a series of cases in which people were presenting with essentially bilateral pneumonia with no identifiable explanation or pathogen. So the SARS-CoV-2 virus, as it's most commonly referred to, what is it? Well, it's an RNA virus, meaning that genetic material within the capsule of the virus is RNA, it's not DNA, and that does come into play a little bit if we get into some of the more genetics discussion. This type of virus is from a coronavirus family, which I think is important to mention because I get a lot of questions in clinic about people checking their household cleaners, and on the back it says it kills coronavirus, and it leads to these questions. Well, how long has this been around? Well, coronaviruses have been around for a very long time. In fact, they account probably for about 10% of colds or common colds or flu-like symptoms every year. That whole family does. In fact, children, about 2% of all children are carriers for coronavirus, meaning they're spreading the virus every day without having any symptoms at all, which is sort of why socially we associate childcare centers and preschools and elementary schools with illness, because if you got 100 kids in a room, 2 of them are probably shedding coronavirus, which is likely to pass on a cold to adults that don't have an immunity to that particular virus. We see the specific SARS-CoV-2 is 97% genetically the same as one we see in bats in many areas of the world. And that's probably the source of where this virus came from ultimately. There was probably an intermediary species there too, as we've learned from some of our other more recent outbreaks. So I think it helps to talk about more recent outbreaks with this in mind. So probably the most closely related outbreaks in recent history are going to be the SARS outbreak in 2002. I think I said 12 earlier. 2002 is when SARS broke out. It infected about 8,000 people roughly and killed about 800. So we think it had about a 10,000 case fatality rate, or 10% case fatality rate. It started in bats again and then jumped into civets. It's like this, I'm not a biologist, I think it's like this cat looking thing that's common in Asia. And then MERS, more recently in 2012, was a far more deadly outbreak of a coronavirus in the Middle East that jumped from bats to camels to humans. Was about 2,500 people got it, and about 800 again succumbed. So it was about a case fatality rate of 35%. how does this virus, the SARS-CoV-2 virus, compare to those two? Well, the one thing we do know is that the protein, if we go back a little bit, the protein that it uses to bind to human cells is 10 times more attracted to the receptors on our cells than the SARS virus. And so with that, we can assume that it's going to be a far more effective transmitting person to person than either of these two, which I think we've seen fairly clearly so far. The other thing I'd stop to say here is going into the data inaccuracy with some of the stuff, especially in the media. You'll see CFR listed on a lot of things, and we have to be careful when we talk about CFR because there's two different CFRs. There's case fatality rate, which is what we see reported historical for outbreaks that we've studied extensively. And then there's crude fatality rate, which is what we're kind of recording right now for COVID too. And that accounts for the reason we see such high variability in our CFRs for the COVID outbreak, because it is a rough guess at what we've got so far and doesn't account for all the undiagnosed cases. Oops, duplicate slide. So graphically, to compare kind of the more recent outbreaks we see, MERS and SARS have a higher mortality rate, but they really weren't very widespread. Seasonal flu has a significantly lower mortality rate, but is more akin to COVID with regard to how quickly it spreads. So what symptoms are we seeing? The symptoms on COVID are actually really interesting. Universally, the most common symptoms we're seeing after people contract this virus is about 5. So the incubation period is 2 to 14 days is about 95%. So 95% of people are going to develop symptoms before day 12 to 14. The median, so 50% of people develop symptoms before 5 days and 50% after 5 days. And that seems to be consistent from China to South Korea to Italy, and even early data suggests in America. The symptoms that people develop tend to be most commonly is the fever is almost universal. The fatigue and cough, shortness of breath are probably the most hallmark symptoms we're seeing after that. I think what disambiguates this viral syndrome from some of the others is you actually have to search pretty hard in these cases to look for somebody with the gastrointestinal symptoms, nausea, vomiting, or the nasal congestion, the runny nose. It's not nearly as common in the COVID outbreak. So I think that helps me intellectually kind of draw a distinguishing feature between the flu, common cold, and this COVID disease. I hear this quite a bit. Isn't this just another flu? You see it on social media. I think people are getting the message now that it's not. And again, some of this data may not be the most fair comparison because we're probably comparing case fatality rate to crude fatality rate. But what we are already noticing is the fatality rate from COVID is substantially higher than your common flu. Part of this is due to the disease itself. Part of it is because it's a brand new pathogen that we have no immunity to. It's spreading like wildfire, and it's oversaturating the healthcare systems in the countries where it's blossoming. And so while we may have been able to suppress the fatality rate should they come in 1s and 2s, when they're coming in thousands, we're not able to supply that same level of care. So kind of where are we at today? So this is as of last night. I think as of this morning, we're at about 225,000 cases worldwide. In America, we've got about roughly 10,000 at this point, with about 100 fatalities in America, but overall deaths about 8,000. So when you compare this to the previous outbreaks of coronaviruses, SARS and MERS, this is on a scale that's unprecedented. And it's probably the only true respiratory pandemic that my generation has seen. I don't think there's been anything quite like it for a long time. But if we are going to try to compare it, and I think that helps because people more closely relate to other pandemics in history, I think the best comparison we have is probably the Spanish flu right around the turn of World War I. Clearly, the Spanish flu was influenced by world events, World War I in particular, and the vast movement of human populations around the world. But but the pathology and the symptoms, maybe not symptoms, but the case fatality rate, it looked to be about the same, somewhere between 2 to 3%. If you look at what it did to the world, it was an enormous societal impact of even low estimates of 20 million fatalities. The difference obviously now is we have a lot more robust healthcare system, but the flip side of that is we have a much larger population in the world. So this is a graph I stole from some folks online. I don't love it entirely, and it isn't actually very clear on my screen anyway, but some of the data on here I don't love. I think it's untruthfully portrayed, but what it does show is that it appears COVID-19 is going to fall on that same spectrum of infectiousness, right, and virulence, or the ability to cause illness and death as the Spanish flu. And so I think it's reasonable to predict some of the behaviors of this virus will be similar to Spanish flu, which is where we're getting a lot of our recommendations from right now. If we continue to follow the Spanish flu example, I think we've got really, really good case reports to show what social interventions do in Philadelphia and St. Louis. So obviously we're taking two sort of the extremes in the nation, but as the Spanish flu broke out, Philadelphia had a Liberty Loan Parade scheduled. It was a war bonds parade, and they decided to go through with it despite the outbreak of the Spanish flu. And in St. Louis basically shut down and had a very effective quarantine process for its population. If you look at the outcomes, Philadelphia, after the parade, within the week, every one of their hospitals was oversaturated, and they had 2,500 people dead by the end of the week. St. Louis, on the other hand, had a mortality rate that never peaked near as high. And so this is sort of what that sparks the flatten the curve conversation we're hearing a lot of on social media. And if you actually look, here you go. So Philadelphia versus St. Louis, you can see that Philadelphia being the solid line here and St. Louis being the dotted, there's no doubt that the effect of the Spanish flu in Philadelphia was dramatically more impactful and lethal. And so what we'd rather see with all these viruses is a flattening this curve, which has kind of become a favored saying, but really what it's referencing is the fact that our healthcare system can take care of most of these people with COVID-19 if they come in slower fashion. Our healthcare system, unfortunately, is not robust enough or built enough to take the surge capacity at the ICU level. This is really important for COVID because what we're seeing, and we've seen it in Italy, we've seen it in China, we've seen it in South Korea, is somewhere around 5 to 10%. Most are saying 6%, but Italy is actually reporting 10% of patients are going to require ICU level care, so mechanical ventilation. The problem with that is there's no country on earth that has enough mechanical ventilation staff and expertise to accommodate that need. And so that's where we're getting into the higher mortality rates at the peak of these illnesses. In fact, in China, you've got a high variability of their mortality rate based on when you get the disease. You had a much, much lower mortality rates if you got it later on, once they had the full apparatus of their set up hospitals ready to go and the surge was passing, versus if you had it at the peak, your mortality rate was exceedingly above 3%. So, and that is an important point, I think, if we look at the lessons from China, that they locked down the region in China where this is breaking out from at about January 23rd, I think was the actual date. And at that point, they only had a few hundred diagnosed cases by sampling. But the truth is when you go back after the fact and look at who was diagnosed, when they have symptoms, when they were exposed, they probably had 10 times as many cases as they actually knew about. And so they were able to, as you see in some of these curves, the gray lines here, they were able to stem the tide at that point. But they did so because they were locking down the country well before they had pandemic levels diagnosed. Because you have to assume that, based on this data anyway, 10 times as many people that have been diagnosed are actually walking around in the community. So what can we do? And I think this, again, I'm going to foot stomp the incubation period of COVID is the median is about 5 days. So 50% of people are going to show symptoms after being exposed before 5 days, 50% after. The range is anywhere from 2 to 12. So that's why you're seeing the 14-day quarantine recommendations. We want to see if you're going to develop symptoms in those 14 days. That should catch about 97% of people. The contagious period isn't as well understood or known. If it's like other coronaviruses, you become contagious at about the time you develop symptoms. The problem with this one is that you see the first symptoms are very mild. You know, a little bit of shortness of breath that's very subtle, a little bit of cough, and that could be it. For the vast majority of people, up to 80%, they never get more than mild symptoms at all. And a lot of us will just kind of chalk that up to something I did yesterday, or the cold, or just allergies. And so you may chalk that up to that and go about your day and walk around for a couple of days before it gets more serious. The symptoms seem to peak sometime around day 8 of the illness, which also disambiguates it from some of the colds that we see. For those that are going to get severe, I should say. The mild illness is 80% of the population. It just settles out within 1 to 2 weeks. So what's important for us to do? Number one, don't panic. There's an adage in medicine which says, if you walk into a room where there's something bad happening, someone's heart stopped, the first pulse you should check is your own. The panic doesn't make for good decision making, and it only spreads fear and further diminishes resources. Practice strict social hygiene. Wash your hands when you're leaving the home, wash your hands when you come home, wash your hands after using the restroom, after touching people, and practice social distancing, which is, I think, getting good penetration in the media and social media these days. 6 feet is kind of what people are recommending. Keep your distance from folks because that's the average cough cloud we create if we cough. But truly, it's close contact, right? We're trying not to come into contact with other human beings. I like to liken this to a box of marbles. If you've got a box of marbles and put 5 marbles in it and you give it a shake, you're gonna have a certain number of times those marbles touch each other. If you take 100 marbles, put it in the same box and give it the same shake, the number of touches between marbles is gonna grow exponentially. What we wanna do is not grow those touches between human beings at this point, because that's how we're gonna stop the virus. And then lastly, if you're having symptoms, call your healthcare team. If you're not having symptoms, I would recommend not calling your healthcare team and just practicing social distancing. The healthcare in every region of the country are going to be overwhelmed very shortly. And so you can do your part by only calling when you have symptoms to let them know and ask for advice. So with that, about 20 minutes in, was I hoping for. I know that is broad strokes and a lot of information really quick. I have a background in genetics, so I could talk forever on this stuff, but we'll open it up to questions.